Hi, Daryl, you may begin.
Daryl, you're on mute.
His Excellency, the Honourable Mitch Fifield, Ambassador and Permanent Representative of Australia to the United Nations. His Excellency, Mr. Vidawat Sivihok, Ambassador and Permanent Representative of Thailand to the United Nations. Excellencies, distinguished delegates, friends, it's my very great pleasure to welcome you to this virtual side event, sharing case studies for change, celebrating and learning from civil society-led responses to HIV and COVID-19 in Asia and the Pacific. My name is Daryl O'Donnell and I'm the CEO of the Australian Federation of AIDS Organisations. Before we begin, I'd like to acknowledge the traditional owners of the lands of Inner Sydney, where I'm speaking to you from, the Gadigal people of the Eora Nation. I pay my respects to their elders, past, present and emerging, and to Aboriginal and Torres Strait Islander Australians who are joining us. 2 days ago, on Saturday, 5th of June 2021, we marked the 40th year since the first cases of AIDS were reported. In the decades since, affected communities, including people living with, at risk of and affected by HIV, have been central to the effective responses to HIV around the world. In particular, the voices of those who are most marginalised, including gay and other men who have sex with men, sex workers, people who use drugs, and transgender people have led the way in reforming policy and legislation and developing and leading responses that meet the needs of these communities. Today, COVID-19 is creating additional setbacks in the global HIV response. These setbacks can be overcome if HIV is re-recognised as an acute public health priority, and we apply the urgency we see in the global COVID-19 response to a renewed commitment to HIV. In addition to this, we've seen in the response to COVID-19 the lessons learned from HIV, that once again, civil society and community-led responses have a vital role in addressing public health challenges. On behalf of all the attendees tonight, I thank regional key population networks for Asia and the Pacific for their leadership and their participation in this side event, and I look forward to a productive and insightful discussion. It's now my pleasure to introduce His Excellency the Honourable Mitchell Fifield, Ambassador and Permanent Representative of Australia to the United Nations. Ambassador Fifield is a former Australian Senator and Cabinet Minister. He took up his position as Ambassador and Permanent Representative in October 2019 and is the co-facilitator of the 2021 United Nations General Assembly Special Session on HIV/AIDS. It's our great pleasure to have him with us today and to provide these opening remarks. Over to you, Ambassador.
Well, thank you so much, Daryl, and it's great to be with so many people who I've come to know during this process and who have been of such assistance to me and Ambassador Gertz from Namibia as we set about this important work. Can I particularly thank at the outset AFAO and UNAIDS and the other organisations involved in hosting today's event, which I'm delighted to do with my good friend, the Permanent Representative of Thailand to the United Nations, Ambassador Vidawat. So great to see you. Can I also acknowledge the important and ongoing collaboration with AFAO and also the National Association of People with HIV Australia, who will join Australia's delegation for this year's high-level meeting on HIV/AIDS. I don't need to tell colleagues on this call that this is a very important time in the global HIV response. And as I said, I'm honoured to be co-facilitating the political declaration for the HLM with my friend Neville Gertz from Namibia. And I've got to say, in taking on this role, I really am building on a strong history of advocacy and leadership by Australia in the fight against HIV/AIDS, and that's something that I do not take lightly. Since the emergence of HIV in the 1980s, Australia's successful response has been grounded at all times in partnership, collaboration between governments, community groups, civil society, researchers, clinicians. It's been a team effort and a full court press. Collaboration to reduce the transmission of HIV, to deliver effective treatment for HIV and AIDS, and minimise social and personal impacts has been at the heart of our efforts. And while the journey hasn't been smooth, one of our key learnings is that the voices of community really are essential. In particular, communities of people living with HIV and those populations at high risk and young people. Communities who, if we are really to make a difference, must have a central role in sharing the views of those most affected by HIV with national governments. Today, AIDS is considered virtually eliminated in Australia, and the transmission of HIV is amongst the lowest in the world. As a global community, we've reduced annual AIDS-related deaths by 60% since the peak in 2004. Now, we should take a moment, pause, and celebrate these achievements, but it has not been enough. In 2019 alone, there were over 300,000 new HIV infections in the Asia Pacific, and almost a quarter of those new infections were in our young people, those aged between 15 and 24. Concerningly, only 75% of the estimated 5.8 million people living with HIV in our region knew their status, and only 60% are on treatment. That is far, far too low. These figures tell the story about individuals, and they tell the story that we need to do more if we are to reach the last mile. Looking to the future, Australia was pleased to support the adoption of the new Global AIDS Strategy. In particular, we welcome the strategy's focus on addressing the inequalities that continue to drive the HIV epidemic. We're also very alert to the difficulties caused by those battling HIV, as well as the COVID-19 pandemic, that concurrent battle, if you like. For example, we are seeing those who are most vulnerable to HIV experience difficulty in accessing testing, treatment, and prevention services because of the greater focus on COVID. We must ensure that the challenges of addressing COVID don't result in a loss of attention to the HIV response. For our part, we're proud to be contributing to regional and global efforts to end the HIV/AIDS epidemic by investing in multilateral health partners, including UNAIDS and the Global Fund to Fight AIDS, Tuberculosis and Malaria. But our engagement in the HIV response is broader than finance. As just one example, the Australian Volunteers Initiative has embedded skilled volunteers in organisations responding to HIV/AIDS in places like Indonesia, Cambodia, Mongolia and Timor-Leste. This year's high-level meeting and new political declaration really is an opportunity to underscore what we know, that full, equal and meaningful participation of affected communities within the HIV response is vital. We have witnessed civil society, you and those who you represent today, moving quickly to protect the most vulnerable and to harness decades of experience and knowledge. You really have done so with dedication, innovation. You've embraced new ways of working and engaging. And can I thank you for your ongoing commitment to ending HIV/AIDS and look forward to a terrific discussion today. Thank you so much.
Thank you, Ambassador, and particularly for highlighting and underscoring the critical role that communities can and do play in the response, not only here at home in Australia, but globally. It's now my pleasure to introduce His Excellency Mr. Vidawat Sivahoke, Ambassador and Permanent Representative of Thailand to the United Nations. Mr. Sivahok took up his appointment after having served as Deputy Permanent Secretary of the Ministry of Foreign Affairs of Thailand, overseeing multilateral affairs. Prior to that, he was Thailand's ambassador to the Czech Republic between 2012 and 2015, and the Laos People's Democratic Republic from 2010 to 2012. Thank you, Ambassador.
Thank you, moderator, and thank you, Ambassador Fifield and all partner organizations for this opportunity for Thailand to join in this important event at the sidelines of the high-level meeting of HIV/AIDS, which will set out the targets and roadmap for the next 5 years. Thailand has always valued the long-standing partnership with civil society and communities in our public health system. Thailand believes in the right of everyone to the highest attainable standard of health, and thereby use the universal health coverage scheme to ensure access and affordability of health services to all persons living in our country without discrimination. At the core of our USC scheme is localization of funding and management, so that each community can tailor the local health system to their own needs and priorities. This, along with the village health volunteer network, has been instrumental in our fight against the spread of HIV and also COVID-19. Our efforts on HIV and AIDS is one area where civil society play a particularly vibrant role in our country. We recognize that the collaboration of different sectors, especially the civil society and the network of people living with HIV, is one of the most important factors in Thailand's success in controlling the spread of HIV and AIDS. In the same spirit with our work on USC and village health volunteers, Thailand recognizes the potential leadership of key populations and supports the model of key population-led health services. These services are need-based and demand-driven answer to the context of each community and help ensure that everyone can access quality services without fear of being stigmatized or discriminated against. The AIDS Research Center of the Thai Red Cross Society, with their knowledge base, have developed the model of key population-led health services. UNAIDS and civil society organizations supported in the implementation of these projects. This demonstrates a truly collaborative spirit between the various organizations and stakeholders. Thailand will also be sharing our experiences on this on Wednesday in the thematic panel on community leadership at the high-level meeting on HIV/AIDS. In closing, I wish to say that I am happy to see that our Asia-Pacific region has many good examples on community and civil society-led responses to HIV and AIDS. I look forward to hearing and learning from all of you today, and hope that we can keep up this collaborative spirit to end AIDS and AIDS by the year 2030. I wish you a fruitful discussion, and I thank you very much.
Thank you, Ambassador, for those remarks. And as you highlight, there are wonderful examples of innovation, of community leadership in Thailand and in our region. And it's those examples of innovation to which we'll turn now. So when there were reports of COVID-19 first circulating, and we were understanding its implications for HIV prevention and treatment, civil society organisations were very quick to respond with innovative action. These responses built upon the years of experience responding to the HIV epidemic. In this session, we're going to focus on the community-led responses to the COVID-19 pandemic, and see how regional key population networks have mitigated disruptions to HIV prevention and treatment services during the pandemic. It's my pleasure to introduce Rain Cortez, Senior Project Manager at the Asia Pacific Transgender Network, as the moderator for this session. Rain is a trans woman advocate originally from the Philippines. As Senior Project Manager, she leads and coordinates projects that build relationships with communities, organisations, governments, healthcare providers, and other key stakeholders throughout the region. Thank you, Rain.
Thank you so much, Daryl. And it's an honor to actually present and moderate this session, which I think is very timely at this time and very relevant, especially that people or many of our communities are actually calling for a people-centered or a community or key population-led responses as an integral part of the 2021 political declaration on HIV and AIDS. So given the persisting challenges brought about by COVID-19 to marginalized communities, many of our communities, including gay men, bisexual men, other men who have sex with men, transgender people, sex workers, people who use drugs, people living with HIV, women living with HIV, and young people have remained strong and resilient at this time and have pushed forward with their advocacies and community-led interventions in response to the various needs that is expressed by their communities, including HIV services for their constituencies. Tonight, we will actually hear stories from community advocates representing people who use drugs, the sex worker community, and of course, people living with HIV. To actually start this session, I would like first to introduce Francis Joseph from ANPUD. Francis Joseph is a voice of people who use drugs in Asia. He is a drug user activist who advocates for the health and human rights of people who use drugs in the region. He has extensively worked in the field of HIV prevention, care, and support for people who use and inject drugs for almost 2 decades. And he is currently the community representative of the Network of Asian People Who Use Drugs, the regional community network. So let's all welcome Francis Joseph.
Thank you, Rain, for this wonderful introduction. Greetings to His Excellencies from Australia and Thailand, and welcome to all participants to this UN high-level meeting side event. I'm sharing our experience on the instant action that was taken by our community warriors and local heroes as an immediate response to the countrywide lockdown in 5 countries, namely Bangladesh, India, Indonesia, Myanmar, and Nepal. Next slide, please. Due to the countrywide lockdown in the countries, our community members were unable to access the regular harm reduction services, mainly the needle and syringe exchange program and opioid substitution treatment, which is offered on a daily basis. We're not able to access drop-in centers, which were also shut, and therefore services were disrupted. Majority of the community members are daily wage laborers who lost their employment and thus income sources. Healthcare facilities were turned into COVID hospitals, and those seeking ARVs were more exposed to further infections. There were no drugs available, and hence those living on the streets faced severe withdrawal symptoms and also hunger. Next slide, please. Thank you. To respond to this emergency and crisis situation faced by people who use drugs, the countrywide networks and community groups came into action to ensure that people are less impacted and are able to avail harm reduction commodities. And the major focus was to ensure people in need of ARVs, opioid substitution treatment, OST, and needle syringes. While Bangladesh initiated a 1 meal a day program, other countries focused to provide essential food items, groceries, and COVID prevention materials. Next slide, please. It wasn't easy actually for even for the community networks and groups to function effectively during the lockdown, and felt that there was a need to liaison with the local administration, law enforcement, and also the government ministries. The immediate initiatives taken by these country level networks and state level networks were, in Bangladesh, the country network approached the National AIDS and STD control program to support for livelihood, 1 meal a day, and also for monetary support to people who inject drugs. In India, being a geographically spread out country, requests were made by the country and state level network to relax lockdown in the areas which were not intensely affected by COVID so that people could avail harm reduction services. Intensive advocacy efforts were put in towards approval of monthly take-home dosages of OST, and also law enforcement agencies and local administration were reach out for issuance of travel passes for free movement of these service providers during the lockdown. In Indonesia, a CBO in Bandung province follows the guiding principles of Indonesia Without Stigma. It's an advocacy event and which is supported by the Ministry of Youth and Sports and Ministry of Social Affairs. A great example was seen where the community groups partnered with local CBOs, NGOs, clinical laboratories for enhanced coverage of key population groups towards provision of food supplies, COVID testing, and provision of prevention kits. In Myanmar, rigorous efforts from the National Drug User Network saw a release of low-level offenders from the groups of people who use drugs, sex workers, and men who have sex with men, with the aim to enhance preventive measures in prisons and to reduce the risks of transmission. This effort was carried out under the President's New Year amnesty. The government approved take-home dosages of methadone and a 6-month dispensing of ARVs. In Nepal, the tireless efforts from the national network led to door-to-door delivery of harm reduction commodities. Law enforcement agencies and local administration was reached out for issuance of travel passes. A technical working group was also constituted, which was led by the National Center for AIDS and STD Control, with under other ministries such as the Home Affairs and the Ministry of Health, the Drug Control Program, to influence approval of the take-home dosages of opioid substitution treatment. Next slide, please. Lastly, I would like to reflect on the key highlights. The partnership between the country and local level networks with the local administration has helped manage the COVID-19 situation systematically and logically. Community-led responses has proved to be instant and efficient. Community members were able to include people who lacked proper identities and documentation to facilitate access to government schemes. Government authorities have seen the dedication and commitments of communities, and hence their perspective towards people who use drugs has been more positive. Joint efforts to respond to the COVID crisis from people who use drugs has demonstrated unity, strength, and courage, whereas we are often underestimated for our capability and capacities. Services and support were made possible only due to joint efforts by local administration, ministries, and donor agency. The key learning that has strongly emerged is personal safety in all aspects related to not only COVID, but also in HIV, hepatitis, and TB prevention. Thank you. Rain, over to you.
Thank you very much, Francis, for that presentation, especially speaking on behalf of people who use drugs, which are often seen as a criminalized population, wherein you are able to maneuver, especially in 5 countries, regarding your advocacies and interventions to provide to people who use drugs, and highlighting the importance of working with local governments, I think, as a joint effort. So later on, we do have a question and answer portion. So for the audience that we have in here, if you do have questions for Francis and Ankud later on, please put your questions and we'll take care of it later on. Thank you again very much, Francis. We'll proceed with the next presenter representing the sex worker community. I would like to introduce Katie Wynn from the Asia Pacific Network of Sex Workers. Katie plays a key role in identifying and creating opportunities for sex workers, analyzing trends, critically assessing new research and policies, and engages in advocacy with relevant decision makers to improve the lives of sex workers in Asia and the Pacific. Katie will actually be presenting their report responding to the challenges for sex workers during COVID-19 in Asia and the Pacific. Let's all welcome Katie Wynn.
Thank you, Ray. And thanks to the Excellency, and thank you to UNX and everyone. And I'm glad to be present about the finding of our assessment report. And the sex worker around the world have been the hardest hit by the COVID-19 pandemic, and it is the consequence. Already sex workers live and work on the margin as a result of the sex worker being criminalized. Sex workers are now struggling to survive impact of the pandemic. The pandemic have created financial and economically instability, increased violence, stigma, and discrimination to the sex worker, which are already faced by the sex worker around the world. In 2020, financial and technical support, or UNAIDS and UNFPA, APNSW completed the assessment of Asia Pacific sex worker in Asia and Pacific that we found that in the study country, sex workers have lost nearly all their income and result of the pandemic. The lack of income has made massive consequences for the individual sex worker and they are dependent. Many sex workers lost their home and also accommodation. Some have moved into their single room to the hostel with their fellow sex worker. Others have moved back to their hometown of their origin. Some are now homeless and living on the street, or feel some with their children. There are being created violence, especially domestic violence. They have also increased the police violence, mainly because of sex workers cannot pay the bribe like before the pandemic. Sex workers have experienced increased stigma and discrimination, largely due to the mistaken belief that sex workers can carry the COVID-19 because their work involves close physical contact. And several due to access to health services, health community, and also the medicine, because many of the health clinic provider reduce the working hour or the stop providing services, because that time is the COVID-19 is the priority to be protect for the people are working. And APNW as well as that our members have responded the pandemic by modifying their existing program to meet their urgent need. For instance, we promote the communicate with our donor and have reallocated the existing program funding to deliver full aid, personal protective equipment, including the condo, personal hygiene, and subsidized emergency accommodation. And also the easy access to the transportation, especially for the sex workers who are living with HIV to get access to their HIV ARD services, including physical and mental health counseling, and access to continuous medicine and care. The rapid action response and relief we have been able to provide demonstrate that community-led organizations are the best positioned to support the sex worker during the crisis like COVID-19 pandemic. However, APNSW and our member have lacked significant of the financial resource to respond adequately. Our assessment clearly indicate that the community-led organization are the most effective way to reach sex worker and during the emergency. They are capable to during the repeat assessment and also the identifying the priority area and reallocating the resource to provide various type of release for the sex worker who are needed. Our established peer-to-peer model is also led by trust and acknowledge of the peer outreach worker and able to deliver the emergency aids and priority to most in needed. However, the largest challenge to the community-led COVID-19 relief work having continued to be lack of funding. We understand the needs of the sex worker and critical care, but the sex worker organization and we still have lack of emergency resource for the response to their need, priority need. I think donors should be able to community-led organization to develop emergency response protocol that will be facilitate the community-led response effort in the pandemic, as well as political crisis and also natural disaster. We experienced that some donors were not ready to be adapted plan with the develop before the pandemic or the crisis. So in this critical, the donor remain flexible to enable community-led organization to deliver essential support services for the community and to ensure that continue to be the virtual HIV treatment, prevention and care. Thank you. Right?
Thank you very much, Katie, for that presentation. I think in behalf of the sex worker community, it's very important to highlight that that doing a report or evidence-based for you to be able to prioritize to whom support should be given. And it also highlights in your session that domestic violence, coming from law enforcers is very common, especially for the sex worker community, and that community-led responses, emergency responses are actually needed to ensure that the support, financial aid are actually coming or going to the communities. So thank you very much for that presentation again, Katie. So for people who have questions regarding the report coming from APNSW or the other organizations that they work with, you can actually post it in our chat box or if you're watching in FB Live. So thank you again, Katie. We'll proceed with our third presenter. I would like to introduce Asghar Sarti, who is the national coordinator of the Association of People Living with HIV in Pakistan. Apart from ensuring HIV treatment, other services provided by Asghar and APL HIV includes education for people living with HIV and key populations on COVID-19. He will be presenting on ensuring access to ARV treatment and enrollment in care during the COVID-19 pandemic. Asghar?
Thank you very much, and Excellencies, distinguished guests, ladies and gentlemen. I thank the organizers for providing me with an opportunity to speak on the sideline of high-level meeting. It is an honor and compliment for me. Thank you so very much. Ladies and gentlemen, it is well-known phenomena that pandemics and infection disease outbreaks have potential to infect and affect severely the range of communities from all segments of society. However, people who have special needs and who have special social attributes may become more adversely affected. The pandemic preparedness relies on the principle of anticipation of community-specific needs and adequate response, driven by the evaluation and review of response strategies. In Pakistan, the COVID-19 cases started to emerge by end February 2020. Within a month's time, by mid-March 2020, the provincial and the federal governments have opted for partial or complete lockdown to avoid further infections within the country. Based on this emergency and after an in-house discussion, the Association of People Living with HIV Pakistan decided to launch and operate an emergency response cell. And during this process, we closely coordinated all the activities with all the key stakeholders, including but not limited to National AIDS Control Program, Provincial AIDS Control Program, UNAIDS Country Office, WHO Country Office, and above all, the communities and the community-based organization working on prevention and testing within the HIV constituency. Basically, the response cell had three major objectives. If you can go to the next slide, please. So first objective was provision of ARVs and ensuring multi-man drugs dispensation to all the people living with HIV across Pakistan. The second objective was provision of social support that includes nutritional packages to all the people, to eligible people across Pakistan. And this was within an aim that lockdown situation further limitized the earning possibilities of people living with HIV. And the third one was provision of information and knowledge to the people living with HIV with regard to the community, with regard to the prevention of COVID-19. Now, there were certain strategies basically which were employed to achieve the objectives. For objective number one, that was provision of ARVs, we carried out very close coordination and liaison with the provincial and the national AIDS control programs, as well as with the ART centers providing the treatment services across Pakistan. So this was the major, methodology that we adopted for provision of ARVs to all the people. Second was provision of nutritional support under the Global Fund grant, and the strategy that we employed that was that we ensured timely dispatch of nutritional packages under the Global Fund grant to support the program and as well as to the communities. Whereas another important thing that we carried out, that was that the government of Pakistan announced various social protection programs, and we decided to link the community of people living with HIV with these programs, for example, ESA's cash program. And on the third objective, the strategies that we employed that includes the use of social media pages of APL-HIV to communicate and disseminate the WHO endorsed messages that were duly translated into local language. The second was communication and approach to the people living with HIV through mobile phones via sending easy SMS or short service messages in the local language to avoid infection within the community. The third one was provision of COVID-19 prevention information and services provided by emergency response cell via already functioning helpline of the APL-HIV, whereas close coordination was pivotal and critical within the CBOs and other partners working in HIV constituency. Now, the major achievements included under the objective number one, we were able to provide the ARV-related information to over 2,400 people and link them with the nearest ART centers. And during this process, we also provided home door delivery of ARVs to over 229 PLHIVs across Pakistan. And this all report is of 60 days of the operation of this emergency response cell. While under objective 2, we provided nutritional support packages to over 6,600 people living with HIV across Pakistan. And this was ensured in face of strict lockdowns across cities and across the provinces and country. Then another 4,239 PLHIVs were linked with ESA's cash program. There was a link that was created between the database of APL-HIV and ESA's cash program. Whereas under objective number 3, as depicted on the view file, we sent almost 151,000 short services messages carrying the information about COVID and to ensure protection against its infection. Whereas another 21,000 people, they were engaged via our messages through social media. And our helpline call during these 60 days received over 4,100 telephone calls from within HIV community seeking the information about COVID-19. Then there were certain people who reacted to our post on social media, and that included over 1,700 people reacting to the social media, and another 1,145 people further sharing the social media messages. In addition to that, we also collaborated with UNAIDS country office to carry out a rapid assessment of the needs of people living with HIV within Pakistan. And we thank UNAIDS for that, as that has been very critical in getting together all the information and prioritize the needs of the community. And for this, definitely, I am obliged to those who supported this emergency response cell, all the stakeholders, UNAIDS country office, WHO country office, national and provincial AIDS control program, and furthermore, the team at the APL HIV who, despite of the fact that there were rapid infections going on, but again, they worked with me and they ensured facilitation for the community. Thank you so much. Over to you, Rain.
Thank you very much, Asghar, for speaking on behalf of people living with HIV. And I'm sure that the three-pronged strategy that you implemented, the emergency response cell, a lot of the PLHIV communities in other countries also have similar interventions in order to provide continuous ARV, nutritional support, cash assistance, and as well maximizing social media to provide both HIV and COVID-19 relevant information. So thank you very much for that presentation as well. Unfortunately, we don't have a fourth speaker. We were supposed to have a speaker coming from the international community of women living with HIV in Asia Pacific. Given that, we will actually be proceeding to our question and answer portion. We have around 9 minutes, if I'm correct, in terms of facilitating question and answer to this panelist, and any question that has been directed in here. Let me see. I do have one question while we wait for the other questions that are coming in. I'll start with a question for actually Francis. Francis, this is a question coming from, I think it's either the FB Live or the chat group. The question is actually, what are some of the main challenges for street-based drug users during COVID-19? Many are homeless, so during lockdown and restrictions, they had no way to go. And how are organizations working around these restrictions?
Yeah, people who live on the streets are quite prone and vulnerable to a variety of infections. Majority of them, a large proportion are living with co-infections of hepatitis, TB, and in the wake of, in the breakout of COVID-19, things worsened when there were lockdowns and they did not have access to even drop-in centers. And some of these drop-in centers have midday meal programs or nutritional support programs also. But, they did not have access to these services, which are considered as a safe haven for people who use drugs. And at the same time, of course, the people who sell drugs, the peddlers, were also, locked down, and they were not out in the streets. So people living on the streets did not have access to their choice of drugs, which further compounded a problem where they were having severe withdrawal symptoms and difficult situations where they did not have money and no drugs. So what happened was that they were experimenting all sorts of things that they could come across, which led to, in many cases, overdose cases and also deaths. The community-based organizations came forward. They had in some of the countries, they had kind of liaison with the night shelter programs, and then emergency spaces were like reserved for people who are beneficiaries or people who use drugs and are registered with the program, or even not registered with the programs, and they were kept in these safe settings. But then there were issues with withdrawal symptoms. So, the further efforts that was put in was to provide them with opioid substitution treatment that could curb their withdrawals, so that, those painful effects and all that could be taken care of. So these were, the responses from the community groups, which has actually demonstrated work which is commendable in 5 countries.
Thank you very much, Francis, for that sharing. I hope the audience was able to learn more in terms of the situation of people who use drugs, especially in most of the South and Southeast Asian countries. Another question posted by one of our audience for Katie. Many sex workers are experiencing an increase in gender-based violence. How are organizations, and in particular sex worker organizations, are providing services for the victims? And has COVID-19 made this better or worse?
Yeah, as I say in my presentation, that during the COVID-19, many sex workers faced the gender-based violence and also the domestic violence. So as the sex worker organization, what we do is providing them mental counseling and physical counseling also who need it. And also that sometimes we provided the legal services who want to take the action or they report it to the police. So that's, and also we're looking at how the safety of the victim, if we need to provide the organization that our member who are working at the national level, they try to provide a safe space for those sex worker, and all the referring to the organization that working on specifically on the gender-based violence. Yeah.
Thank you very much, Katie. I think it's very important to actually provide safe spaces, especially for different key population groups that normally sex worker, transgender people, or gay men cannot go back to their own families. And they actually need safe spaces, which are actually provided by community members or community groups. Yeah. Thanks again, Katie. I do have a question for Ashgar. Ashgar, the question from the audience is, people living with HIV are not able to access HIV prevention and treatment services because of lockdowns and restrictions. How are some community-based services are getting out the info to hard-to-reach vulnerable communities, especially those who are disconnected or have poor digital literacy?
Okay, thank you. Basically, we mainly work around people living with HIV, and like I said during my presentation as well, that the main focus was to ensure that people, they do have, the ARVs available, not only for 1 month, but as per WHO guidelines, it was to ensure that they have multi-month drugs available to them. Your question, probably what if correctly I understood, is more towards prevention and testing services, and that is true that was totally almost closed down because of strict lockdown during the first wave of COVID-19. But I mean, once the PPs started coming in, then the communities, they again started approaching their respective key populations, as well as and a coordination kind of thing that was ensured with law enforcing agencies, that to sensitize them that why it is important for them to move on and to have access to their communities. So basically there were different, I would say, strategies those were employed to ensure that both the key population as well as the people living with HIV, they have access to the services. But with regard, I would like to share more of the experience of working with, and that was that although but it was hard for the community people to reach because of the lockdown situation. So what we did is that we worked on 3 dimensions. Number one was that the provincial offices of the APL-HIV, they had close liaison with the provincial programs, and we had links with their warehouses as well. And secondly, some people, they were stuck in different areas. So we linked them with the nearest possible, centers. And we, in this case, we also mobilized our community-based, groups, the community support groups, and those facilitated. Their names were shared with the ART centers, and they picked the medicines and they provided them. And on other hand, we also, at the central level, we have, close coordination with National AIDS Control Program, and they gave us a free hand to contact their warehouse and confirm that what medicines are required, and those were, dispatched through the community support groups as well as through the courier companies. So these were different strategies those were employed to ensure that the people, they do have access to the required services.
Thank you very much, Ashgar, for that very detailed additional information. We do not have much time, but I would just like to give Francis and Katie a brief 30 seconds, perhaps, just to answer this last question about what do you think is the key highlight of your community interventions, and what do you think is a successful one that needs to be scaled up? Based on your experience, maybe just a quick sharing for both Katie and Francis. Francis first.
Okay, Rain. There have been endless experiences during the study time, but then I can primarily highlight about the opioid substitution treatment, which in some countries is methadone and in some countries is buprenorphine. And the legal and regulatory policies has banned and limited take-home dosages of these medications. But during the COVID pandemic, these was kind of, relaxed by the governments, and people were able to take these medication on a take-home dosage was granted. And it happened not only in the 5 study countries, but in many countries across the world. Yeah.
Thank you very much, Francis. Maybe the last word from Katie.
Thank you. That in our experience during the COVID, what we found that is the support of donor and flexible was very important for the community to respond their priority needs and urgent. Because of that, most of our donor are flexible. So during that time that we have advocated to our donor for reprogramming, and then we have supported for the emergency response in the 11 countries for the sex worker community in terms of the reprogramming, and also in terms of providing the other needed, including the safe space. So what I understand is that some of the thing is most of the organization in the community, and also in the government, and also the UN need to support the community for it's the emergency responder planning. And when we face those kinds of crises, and we don't need to, the policymaker should not take long time for the approving. So then we can immediately respond to the emergency, which most impact to the community level in the grassroots. So this is I want to say that as from me, as the community, the recommendation that donor should be flexible and government should be immediately respond and allow for community to do it. Thank you.
Thank you very much, Katie. So I would like to actually congratulate the 3 of you community advocates to actually share your experiences in here and highlight really the importance coming from community perspectives and the community-centered approaches, especially on this political declaration for HIV and AIDS. So we finished this session, and I would like to give the floor back to Daryl.
Wonderful. Thank you so much, Rain, but also to our speakers, to Francis, to Katie, and to Ashgar, not only for sharing the wisdom that comes from lived experience and from deep and authentic connection to community, but also for reminding us about the power of community responses in COVID-19. In the next session, we continue the conversation on community-led responses, this time focusing on innovative HIV prevention services and programs. So several countries in our region have experienced a decline in new HIV infections of more than 50% between 2010 and 2019. This is largely due to strong leadership that has facilitated successful and diverse models of differentiated HIV service delivery, including HIV testing, multi-month dispensing of HIV treatment, and key population-led health services. However, there's a great deal of work ahead of us to sustain and improve upon these gains. Additionally, while our region has experienced a general decline in new HIV infections, there are 7 countries where HIV has increased between 17% and 207%. Disparities continue to emerge in key populations that are disproportionately affected. And of particular concern are young people from key populations and their partners. In 2019, around a quarter of total new infections occurred among people aged 15 to 24 years. This session features speakers from Australia, from Thailand, and from Indonesia, each showcasing innovations in HIV treatment, prevention, and testing. I'm delighted to now introduce Sanal Mehta, Regional Director of the International Planned Parenthood Federation, who will moderate this session. With 142 member associations and a presence in 170 countries, the International Planned Parenthood Federation is the largest enabler and provider of sexual and reproductive health rights, services, and information globally. Thank you, Sanal.
Thank you, Daryl. Respected Excellencies, delegates, UNAIDS officers, civil society members, community leaders, and my friends on this call. Necessity is the mother of innovation. Civil society, community leaders work straight with the community. We have to respond to the changing needs, changing environments, changing circumstances, and that, even if you don't want to, pushes us to really make sure that we are innovating repeatedly. Also, the world knows that we cannot treat our ways out through this epidemic, be it HIV, be it Corona, be it whatever. Prevention has to be a central stone for any public health good. So we are going to today listen to very powerful presentations from 3 of our speakers that from different countries that Daryl already explained. To actually start the session, I'm going to first invite Matthew Wogan. Matthew is Acting Director of HIV Sexual Health and ECON's Principal Campaign Planner, where he leads the strategy and development of multi-award winning campaign, Ending HIV, which seeks to end HIV transmission in a state in Australia, NSW. Matthew has been working within the community services sector for past 15 years, working in a variety of roles within government, non-government, and community-based organizations at state, national, and international levels. I'm going to invite Matthew. I'm going to request all the speakers to keep their presentations to 5 minutes so that we have more time for discussions. Over to you, Matthew.
Thank you, Sanal, and I'll promise I'll keep to 5 minutes. As Sanal mentioned, my name is Matthew Vaughan, and I've been tasked with talking about Australia's community-led responses to HIV. Australia has a long history of community-led responses, and while the examples I'm going to talk about today will focus mostly on gay and bisexual men, I also want to acknowledge other communities who are important to us in Australia's HIV response. These include people living with HIV, sex workers, trans and gender diverse people, people who use drugs, and our First Nations people. Change slide, please. For almost 40 years, the Australian HIV response has been grounded in partnership. This has been made up between 4 equally important pillars: communities or key populations, governments, research, clinical providers. It's through this partnership that Australia can be proud of the sustained elimination of HIV among sex workers, incredible low rates among injecting drug users, and people also incredibly low rates around people who use drugs, and more recently, significant reductions among gay and bisexual men. This is because governments in Australia acknowledge that communities are more than just passive recipients of health. Next slide. For example, community education has been the foundation of the HIV response. In early years, when information and resources were scarce, groups of gay men would come together and share what little information they had, trying new strategies and then passing that information on to others. Change slide, please. If we use the example of the mighty condom, originally intended to prevent pregnancy, gay men started using these not even knowing that if they would prevent HIV. The idea of gay men using contraceptive was unheard of, laughable even, soon to be embraced by most thanks to community education and targeted community campaigns. And the importance of community education has proven to be true time and time again, with messages around PrEP and encouraging early treatment access. Community education is what is at the heart of what we do. But communities and key populations can do much more than demand generation and education. More recently, we've seen the value of community members in clinical spaces, whereby peers or community members are trained and accredited to provide healthcare services like HIV testing. Change slide, please. In Australia, we call these community-based testing. These services are co-designed or established by community organisations in partnerships with clinicians and funded by government. ATEST provides free and confidential HIV testing and sexual health for gay and bisexual men, performing approximately 10,000 tests a year. The clinic is staffed by peers, other trained gay and bisexual men, as well as a nurse who's provided by the local sexual health clinic. We recently evaluated this service, and the evaluation found that while ATEST accounted for about 1.3% of HIV tests in our state, which isn't a huge number, I know, the service accounted for more than 13% of all HIV diagnosis among MSM. And that number increased when we looked at migrant MSM populations. ATEST was responsible for diagnosing 20% of those infections. Through ATEST, we often see people who have infrequently or never tested for HIV. Clients love the experience with a peer. They find them relatable and non-judgmental. And while these are just two examples that demonstrate the abilities of strong and engaged communities, and I could continue with many more, I know that Midnight and Asvan are going to show you some other great examples. There's been some great presentations already today during this session, all of them amazing. But if I could part with just one lesson based on Australia's 40 years of experience of community-led responses in Australia, that would be the importance of having a strong, well-resourced community organisations. Because the reputation and trust that develops between these organisations and their communities doesn't happen overnight. And that's why sustainable funding models that allow organisations to invest in the capacity development of their organisation and their staff is possibly the most critical lesson to share. Thank you. Back to you, Sanal.
Thank you. Thank you so much, Matthew. Your strong and direct message. Put the money where the mouth is. I think that is a very, very important message. The second important message for me was demystifying health. And I think that is one of the major reasons for success of HIV programs, I think, worldwide. From one powerful presentation to the other, I'm going to now invite my friend, longtime friend, Midnight Pun Keset Watana. Midnight is an executive director of EPCOM based in Bangkok, working in multi-sectoral partnership with governments, donors, the United Nations, development partners, and most importantly, the community and civil society organizations working on advancing SOGIE's rights, elevating HIV in Asia Pacific region. Midnight, I always love listening to you. Over to you, please.
Swadee. Good evening, everyone. Thank you so much for inviting me to this wonderful session. And I see old faces again, Sanal and Matthew. Yeah, very good friends, obviously. And And very important to have this discussion just before the high-level meeting, which we all want to see really strong language coming out globally and particularly for Asia Pacific region. The epidemics is really amongst the gay and other sex with men of 44% of the HIV infections, particularly young gay men between 15 and 24 years old accounts for 52% of new HIV infections. And the previous panels talked about the other key populations, and not many are aware of the HIV status, and not many people are able to receive HIV prevention services. So this is a really important session that we need to talk about. And this session we want to talk about pre-exposure prophylaxis as well, which we want to make sure that it is at scale. Next slide, please. So as Sonal mentioned about APCOM, we are the same as other regional networks, cover such a really wide range of countries and communities, but the importance is really working with the communities on the ground. And APCOM also, emulate those kind of community-led approaches. And what we like to do is to incubate the possibilities that community-based organizations can also be a fundamental part of the national health responses, be a national health systems as well. So on the slides that you can see now, we have done some online HIV testing campaigns. We have formed groups together to talk about pre-exposure prophylaxis in our region, how to roll that out. We have information on PrEP in our region. We have webinars last year talking about understanding U equals U, which is staying on treatment and being undetectable. And recently, we just launched together in partnership with UNAIDS a qualitative study on the review of Asia region amongst MSM and transgender women on sexualized drug use, so which we call chemsex, which is really phenomenon has been happening for a long time, but it's really not really being factored in our programming currently. And then, of course, so we have a slide, photo there showing about PrEP, how do we then talk about PrEP in a language that our communities understand. Next slide, please. Just to give you a brief sort of overview of why it's important to be able to reach a younger gay men, other sex with men, and using the test PKK, which is part of our APCOM's work on HIV online testing. As you can see here, our performance in 2020 as just one organization, there's a big reach. I think there is a way that we can also ensure that other communities have the skills and have the people and have the resources to be able to use the tools that's available to ensure that there is communication going out to the communities and be responsive to what the community needs are, to take them to HIV testing services that is also trusted by the communities, that we know if someone young, 18 years old, going to this particular community-based clinics, they will have a really good experience. They will not be discriminated against. They will then tell their friends until they come to these services because they treat me as a human being. They don't discriminate me because of my sexuality, because of my work or anything else. They just want to, they want to see me get the treatment that I need, or the prevention package that I need. So in terms of prevention, we also been able to disseminate condoms and lubricants through online work. And then you can see all the engagement on Facebook, on Twitter, and the other online platforms. So there's a lot of engagements out there that young people are really going online now, particularly with COVID-19. Next slide, please. Talking about COVID-19, just to give you an example of what APCOM has been able to do under our Test BKK campaign. So the condom package, party packs, that's what we called. Just when did Thailand get into lockdown? So end of March, so April, May, June, April, May, June, we did this campaign online where they can order the condom packages, and within the packages you get the condoms, lubricants, and also harm reduction materials as well. So that last 3 months, 48,000 condoms were distributed, and then more than double the online bookings or reservations that we had the previous 3 months. So it shows that just because there is COVID-19, it doesn't mean that people are not interested in sex. People still want to have access to prevention packages. People still want to be able to have safe sex. So how do we ensure as community organizations we are able to provide that to our communities? Next slide, please. And And it's not just about, the talking about health only, right? It's about any other things that might not be programmed yet at country level. So you talk about sex, we could talk about hepatitis, and then we could talk about drug use. So here there are some materials on drug use, and also how to do CPR when there is, when your friends might be overdosing, and talk about PrEP and not to PrEP, why, and having those discussions is really important. That there is constantly update of information for the communities, particularly when in COVID-19 there's a lot of misinformation out there. So community-based organizations must be able to make some trusted information that can be referenced and then send it out to community leaders that they can then disseminate as well. Next slide. So this is like my last slide. We cannot do this just in Bangkok. It has to be other countries as well. It needs to make a movement. It needs to be something that can be seen outside your particular region. So how do we ensure that the message is consistent across all the regions? So the scaling up of community-led approaches is really important. So the example that I've given here is what we've done. And actually Matthew has been part of this to ensure that there is information out there on the testing and using the testing messages to get communities into the services to then talk about treatment, to talk about prevention. But this is done by the community-led approaches. And as Matthew has said, it's important that these community-led approaches and messages, particularly on the positive, sex image, and being able to talk about, sex in a way that our communities understand, has to be there. It's not just about the biomedical interventions only. So that's it. Thank you so much, Sunil, and thank you so much, everyone.
Thank you, Midnight. Again, two important messages: intersectionality, multiple vulnerabilities, and need for PrEP. Many of our countries, unfortunately, don't have the new modern prevention methodologies. I need not repeat. If anybody has questions, please put it in chat. We already started having one. I'm going to now, we have heard two very strong speakers, their experiences with gay and other men who have sex with men. We are going to now listen to experiences with young people. I'm going to invite Azwain Hamza. Azwain is from Inti Muda organization, which is based in Indonesia. It's an Indonesian youth organization formed in 2018. Organization is also young, along with the people working there, to respond to HIV prevention and the fulfillment of sexual and reproductive health rights of young people, key population, and youth groups most affected by HIV in Indonesia. Inti Muda Indonesia builds partnerships with key populations and conducts advocacy to fulfill the rights of young people and key population. Can I invite Azwain? Please, over to you. Thank you.
Thank you, Sonal. Thank you, Daryl and Rain. Thank you for UNH AFO, and all greetings for all panelists here. Okay, can I see the presentation here?
Can we have the slides, please?
Yeah. Okay, sharing case studies for change, also on innovative prevention strategies for young key population using digital space and new reality-free models. We need to acknowledge that COVID-19 becomes one of the main focus on how we conduct innovative strategies and new delivery models. Okay, next slide, please. As you guys can see, basically HIV epidemic, especially in case get HIV and IRT in youth, which is for 14 years old to 24 year key population, has shown specific data as you guys can see on the screen like this. The estimated number of people living with HIV is about 68,825 persons. Those who start access the ART is about 34,128 persons, and those who access ART in a stable way is about 21,041 person. Those who got their VL suppressed is about 3,344, which is only 4.8% from the total amount of estimated number of PL-HIV. Based on this situation, Inti Muda Indonesia conducts several programs with our main scope of work in provide sexual reproductive health rights information comprehensively as a form of prevention action in suppressing the amount of new HIV/AIDS infection on YKPs on young key populations. Those programs are, next slide please. Those programs are Lollipop and I Am Buddies. First, Lollipop. Lollipop stands for Linkage of Quality Care for Young Key Population, which focus on YKP's friendly approach in HIV. The term Lollipop itself used as an interesting youth program matched with the needs of YKP itself, with its name, logo, and color, something like that. An interesting youth program color. Lollipop are intended to target YKP to access the VCT in healthcare provider and getting adherence wisely. So as you guys can see, Lollipop has 4 main components. First, strategic information, enabling environment, also increased demand, and the last in enabling improve supply. Lollipop itself spot a few recommendations for future possible work, such as, next slide, please. These are the recommendations that Lollipop program has spot. First, utilizing and following up on the findings of the strategic information of Lollipop that has been produced, including HIV cascade in adults and in several cities in Indonesia. Next, conduct bottom-up planning to ensure programs that is matched with young key population need, as well as strengthen the ownership and sustainability of the program. Next slide, please. Okay, here we go. Here we have IM Buddies. Actually, IM stands for Inti Muda, our name of organization. IM Buddies is a form of outreach program in reaching those YKPs under 18 years old in particular. IM Buddies provide outreach and assistance in access VCT and ART treatment services in healthcare provider for those under 18 years old YKPs. For early adolescent, if you guys can see. But these are challenges and barriers, you guys see on the screen. Challenge and barrier: first, several healthcare services require the approval of parents or blood-related family, referring to Ministry Health Regulation number 74/2014. Bring a family identity card or at least a photo, statement letter, or MOU. Second, there are still, limited programs targeting teenagers under the age of 18 itself. Also, IM Buddies spot 2 recommendations, such as first, needs for youth outreach program under the age of 18 in a massive way, and legal protection for outreach workers, especially teenagers. Now, speaking about COVID-19 pandemic, which became the barrier itself for both programs, Inti Muda Indonesia try to solve and adapt both methods safely with COVID-19 prevention, such as provide extra higher information through social media to Inti Muda family in all around cities in Indonesia. So for outreach action, we conduct interesting methods in reaching YKPs in assessing VCT service, which we use our network with one of those outreach community to do the test at home with HIV self-test kit, such as finger prick test. And the outreach workers are capable to visit YKP at their home also with COVID-19 procedure and protocols to prevent the transmission of this virus. As we all know, HIV self-test itself provide a valid result for non-reactive result, but require a confirmatory test for positive result. So these methods contributes in minimizing client in healthcare services. So there will be less people and then also less physical contact. And last but not least, dealing with this COVID-19 pandemic, Inti Muda Indonesia with our 8 family members in region all around Indonesia held several innovative events when the numbers are getting down, the local lockdown are getting stopped. So those activities such as IM Festival in its cities, IM Talks, which is a dialogue competition to ensure that YKPs are engaged with current issues and sexual reproductive health info update, and also several online talks between Inti Muda family member with professional speakers. Thank you.
Oh, fantastic. Thank you so much, Aswan. Again, 2 very important information we get. We have to learn the new language. IM Buddies, Lollipop, and to listen. Your point about legal protection to service providers is very important. I think that is one of the biggest challenge. Okay, we will quickly go to question answer session, and I'm told we don't have too much time left. I have one specific question for Matthew. I'm going to ask him that, and then I'm going to ask a common question to Asghar and Midnight together, which talks about minimum package without which we cannot compromise. So you prepare while I go to Matthew. Matthew, the question to you is, has AFAO found any success in social media campaign to promote and scale up HIV testing among MSM, bisexual men and men who have sex with men?
Thanks for that question. It's a really good question. And I think, Yes, I think we can definitely say that AFAO and AFAO's members have had a lot of success through, targeting MSM or gay and bisexual men through social media. So across the spectrum, so Facebook, Instagram, and also the applications. I think one of the things that we're constantly aware of as, is that this is a changing space that happens, by these private companies. So recent examples with Facebook where they change an algorithm and that completely drops off. So it means that we can't be solely reliant on social media, and that traditional forms of outreach that we do through peers and peer education and into bars and clubs is also still very important, and not to become too reliant on, only using Facebook, for example, because that can change quickly.
Thank you. Aswan, there are quite a few questions for you, so I'm going to ask you something different now, not what I had suggested earlier. So I'll quickly ask you the question, Aswan. Lollipop and I Am Buddy outreach programs are very important to ensure access to HIV services among young people. What have been the main challenge in the implementation of Lollipop and I Am Buddy, and how these challenges have been overcome? If you can quickly share the lessons learned.
So about the challenges between Lollipop and I Am Buddy itself is, I think the parent consent is a serious barrier that we need to talk, especially during this COVID pandemic for YKPs under 18 years old. Let me make it quick that, in fact, there are some public healthcare services that is only needed outreach worker to assist YKPs under 18 years old to get the VCT test done. This is how we deal with it. This is how networking in community is become the main solution to solve the barrier that we are facing now. Also, besides, we have discussed with these issues with AIDS countermeasures coalitions on Bandung, West Java, one of regional in Indonesia. They show the same exact expectation and response with us. This challenge, the institutions are totally aware and welcome with 18 years old assistant program without getting their parent consent. This will be a serious recommendation and chance for us, community and stakeholder, in working on how VCT service are totally capable and accessible for all groups in society. So I think about the challenge is, yeah, we're still trying to deal with it, but there are several stakeholders from the government itself, from the community itself, which support us in a silent way. Thank you.
Fantastic. I was going to ask you, how do you convince parents, but we'll talk about it some other time. Midnight, very quickly to you. There are a couple of questions, but I'm going to pick up the toughest one for you. What would you say your minimum initial package for HIV services during crisis and disasters? What is absolutely non-negotiable?
Wow, so now that's really difficult. But I would go back to what our Excellency Mr. Witawat Sihope mentioned earlier on about the key population-led health services. So I think I'm very proud as a Thai person that we have this as a model that the government is now supporting and looking to support that sustainably, and going through the community-led health services to understand what the community needs are. I think that should be the absolute non-negotiable, and see what are the community-led intervention should be according to what the community needs are and the changing needs. Because as we have seen, we are still pivoting to COVID-19. Thailand is going through its third wave. We're waiting for good vaccine rolling out. So I think there's a lot of this different changing, and the needs are going to be changing. And the way that we will come out from COVID-19 and the interventions that's going to be needed in terms of packages will be different to previous years. But what will be the non-negotiable would be the engaging with communities and having that regular communications with community organizations and members. Thank you.
Fantastic answer. Thank you, fantastic panelist. Over to you, Daryl. I've been constantly reminded we are running out of time. Thanks a lot.
Sunal, thank you to our panelists, to Midnight, to Matt, to Asvan. Thank you so much. And in particular for actually bringing forward the passion that comes with key population, community-led service delivery. This isn't just the right thing to do. It's more effective and more powerful when services and programs are led by communities. And part of that is about the passion, the commitment, the dedication that comes through in the presentations you've given. It's my great pleasure to introduce to each of you now Mr. Eamon Murphy, UNAIDS Regional Director for Asia and the Pacific, and also Ms. Jules Kim, who is the Asia Pacific representative to the United Nations NGO delegation to the Program Coordination Board, who will both offer their closing remarks. So Mr. Murphy is the UNAIDS Regional Director for Asia and the Pacific, and in this role he supports countries across the region in achieving the goals outlined in the 2016 United Nations Political Declaration on Ending AIDS. He leads and facilitates a joint United Nations response to support countries and their HIV programs, which includes strengthening the links between governments, civil society, and the United Nations system and development partners. Mr. Murphy has previously served in Myanmar and Vietnam as UNAIDS Country Director and in UNAIDS headquarters as Director of Governance, United Nations System and Donor Relations. He's joined by Ms. Jules Kim, a Korean-Australian sex worker and the Chief Executive Officer of Scarlet Alliance, the Australian Sex Workers Association, which is the peak national organisation representing sex workers and sex worker organisations, collectives and projects throughout Australia. Jules is the chair for the Regional Sex Worker Network, the Asia Pacific Network of Sex Workers, and is UNAIDS Program Coordinating Board NGO Delegate for Asia Pacific for 2019 to 2021. She's also a representative on the multi-stakeholder task force to the 2021 high-level meeting on HIV/AIDS. She has over 20 years experience in sex work, advocacy, community development and representation. I'm delighted to welcome both Eamon and Jules. Eamon or Jules, over to you for closing remarks.
Thanks very much, Daryl. Jules, do you want to go first?
Gentlemen first, Eamon.
Okay, all right, we won't debate. Okay, thanks, Jules, Daryl. It's a great pleasure to join the panel. This is the second event from Asia Pacific in the run-up to the high-level meeting. There was a fabulous event earlier today with young people from across the region, reaching out across the world, actually, Africa and other parts of the world joining into their discussions. So today, firstly, let me offer appreciation and thanks to the whole range of partners, the governments, of course, of Australia and Thailand for their strong leadership, unwavering support throughout not just these events of the high-level meeting, but over many, many years. AFAO, Asian Network of People Who Use Drugs, APN+, the people living with HIV, the Transgender Network of Asia Pacific Coalition of Men's Sexual Health, or APCOM. We know many of these by the acronyms better than the full names, of course, over time. And Asia Pacific Network of Sex Workers, and really impressively, young people through Youth Lead today as well. Firstly, in reflecting on what we've heard today, the most important thing are the experiences that community is showing that they've been doing for a long time, but how they continue to innovate and are at the forefront of the response to HIV. But importantly, the intersectionality that came out of how to respond to the impact of COVID-19 as well, and how governments have turned to both the government programs on HIV and to the communities working on HIV to help in leading the response for COVID-19 as well. My special thanks to Ambassador Fifield and Ambassador Vitivas for joining us today and sharing their reflections and being with us throughout the whole panel. We know this is a very busy week, and particularly for Ambassador Fifield as the co-facilitator, it's going to be a really important week as we come together to have that political declaration that we all want to see for Asia Pacific and for the world as well. So a couple of highlights from this morning. Firstly, the voice and role of civil society is essential in all elements, the design, the implementation, and the monitoring of national responses, as well as community-led responses as part of that. Access to prevention treatment services. It's urgent that we scale up and reconnect to the energy that was there in the response earlier in the period. We are lagging behind, and the rest of the world, but we are also seeing, as Ambassador Fifield mentioned, others touched on, second wave epidemics starting in countries. And we have the fastest growing epidemic in the world in the Philippines. So it shows quickly how things can change if we're not focused. The new innovations, PrEP, self-testing, the online access, reigniting a harm reduction response, which has really slipped behind. Comprehensive sexuality, making sure all the key populations get the services where they need it most. So service delivery needs to be modernized. The funding, domestic funding in particular, to community-led and civil society organizations directly to integrate, because we know even more today with the rising conservatism and stigma and discrimination, the most effective way to reach people at risk of HIV or living with HIV is through the key populations themselves, right? And that's where young people today want to hear their messages, as we just heard from Matthew, how dynamically changing this is, you know, and they have to have programs targeted for them by people, as Asvian showed us, that understand them in their local context, and that's critical. Importantly, obviously, upholding and protecting human rights. That's where the political declaration is critical for the next 5 years. We need a recommitment to the importance of human rights for key populations, vulnerable groups. COVID-19 has shown us again how this can quickly turn into a very negative and nasty experience for people when the blame starts about transmission of a virus. It's just reminded us of things we've known. 40 years ago this weekend was when HIV was first identified. And we know from our strong experience and sad experience for many of stigma and discrimination and the importance of the placing human rights at the forefront. We still have 37 countries across the region with many forms of criminalization of key populations or behaviors. And this is just not the way to go forward. It's certainly not what should have been in place already. So this is critical. It's not just for HIV. Hepatitis, TB programs suffer similar. And COVID-19 is showing us again, the most marginalized in society are those who are going to get least service, but we can't respond to an epidemic unless we are responding and supporting everyone in it. So the inequalities, that's the critical thing, and that's why the new global strategy is framed from inequalities. We talk about enabling environment, use many words, but the inequalities that people face in society, the patriarchy, the discrimination that undermines progress to the response to HIV and propagates gender-based violence and other things. Quarantines in COVID have shown us again, communities limited to their homes and places, and cases of clearly unsafe and violent experiences. COVID has exacerbated these socioeconomic inequalities and shown us again, like HIV showed us 40 years ago, viruses do not follow borders. We need a regional and a global response. One country doesn't do their part, other countries will suffer. So this is why the political declaration and the critical work of delegations like Thailand, who's working with ASEAN and other member states, not just for Thailand, but across the region, and the great leadership there, as well as Australia from our region as the co-facilitator. This is critical for us to look at these issues, the social protection, the other dynamics, intersectionality across aspects of the response that's required. The funding, and that's critical, the domestic financing is going to treatment, but slowly at a drip pace, and certainly running away from prevention. And that's critical if we're going to put a halt to these new wave epidemics. It's critical that we see domestic financing, particularly for community programs and community-led responses, increase significantly in the next 5 years. We have not met the 2020 targets across the region, and that's clear from what our colleagues said, but also the innovations that they showed is why it's so critical to partner, because the community are at the forefront of the innovations that are really going to keep us on the front foot in responding. So, ambassadors, colleagues and friends who are online, ending the AIDS epidemic is only achievable if the key populations are not left behind. COVID-19 showing us, again, many are left behind. We should ensure that the right people access the right services, which are delivered in the right way by communities and with the innovation required and in the right places. The participants here today, on behalf of the communities they speak for, often people are afraid to speak out for themselves, and that's why it's great to have such brave individuals publicly speaking for their communities. All the participants have urged member states to focus efforts and resources where they're most needed, and importantly, to adopt the political declaration that explicitly recognises who is most at risk of HIV and acknowledges why this is so, and to commit to fully fund and support effective responses. We need to seize the moment, commit to taking the actions that are required to end AIDS globally, but then after the high-level meeting, we need to work together to have a new roadmap for Asia Pacific to put AIDS back on the agenda in a stronger way. Thank you. Back to Jules first, and thanks everyone for the great work with the high-level meeting. Community are leading the way in getting the messages through their governments. Thanks very much. Over to you, Jules.
Thanks so much, Eamon. Thanks for that great speech. And I just want to start by thanking His Excellency Mitch Fifield and Vitawok Sivihoc for staying with us through this session, and also to FAO and UNAIDS for supporting this section, as well as all our amazing speakers, moderators and community leaders, and also to all of you who have stayed with us throughout this panel to hear about the situation and key population-led responses in the Asia Pacific. Now, we've heard about the continuing challenges faced by key populations in the Asia Pacific. Daily, they face an environment of pervasive stigma and discrimination, criminalisation, and other barriers to HIV prevention, treatment, and care. But despite this, we've heard inspirational stories of how community-led responses have withstood these challenges to deliver critical life-saving services to their communities, ensuring, even in the most difficult circumstances, and despite severe underfunding and resourcing, that key populations, namely sex workers, gay men and other men who have sex with men, transgender people and people who use drugs, and people living with HIV, have responded to ensure that their communities are not left behind. Key populations are widely recognised as the pioneers and leaders of the HIV response. And since the emergence of HIV, key populations have led the way in pioneering effective prevention responses and sharing those knowledge and skills with their communities, as well as providing essential care and support. Communities also spoke out to challenge their governments and donors to do more and to act to save lives of people living with HIV and key populations. Yet sadly, we've continued to hear these critical elements to an effective HIV response being challenged and even denied by some member states. In some cases, our very existence is denied, and our communities are routinely face barriers to accessing services and healthcare. We are harassed, persecuted, and arrested just because of who we are, who we love, our sex and gender, and our lifestyles, and how we earn a living. And despite the mountains of evidence of key populations and community-led responses, the recognition of community-led responses remains largely absent. We call on you to continue to mobilise for greater support and resourcing for community-led responses for HIV. The Global AIDS Strategy, and importantly the drafts of the political declaration, articulated the need to end inequalities and to address the structural barriers with critical 10-10-10 social enabler targets, calling for member states to end all inequalities faced by people living with HIV, key and other priority populations, by reducing the number of women and girls, people living with at risk of and affected by HIV who experience gender-based inequalities and sexual and gender-based violence, and by reducing the number of countries that have restrictive legal and policy frameworks that lead to the denial or limitation of access to services, and to reduce the number of people experiencing stigma and discrimination, all by 2025. Equally important is the call to increase the proportion of HIV services delivered by communities, including by ensuring that by 2025, community-led organisations deliver 30% of testing and treatment services, 80% of HIV prevention services for populations at high risk of HIV, including key populations, and 60% of programs to support the achievement of social enablers. The stakes remain high, with over 75 million people who have become infected with HIV and over 32 million people who have died illnesses since the start of the global AIDS epidemic. Community-led responses work. Key populations, their networks and organisations must be resourced and supported to do this critical work within their communities. And we must work to address inequalities and break down the structural and legal barriers in order to meet targets to end AIDS by 2030. I thank you.
Thank you, Jules. Thank you, Eamon, for those closing remarks and so beautifully bringing together today's discussion. Thank you, Excellencies, for joining us, for your leadership and the leadership of your governments as we step towards the high-level meeting. And thank you to each of our speakers who have come together tonight to share their stories, but also their expertise and to inspire us with the leadership, with the innovation that's occurring right throughout Asia and the Pacific through community-led responses. I'm very glad to have been able to host this session with each of you tonight. And on behalf of AFAO, thank you for joining us.